Very few cases of PAD treatment are performed transradially. And the reason for that is, first of all, is the mindset. So all the interventional radiologists and the vascular surgeons have been trained to use the femoral artery or even the brachial artery, but the radial approach comes from the coronary work. So number one reason is the training. So we have lack of training. Second, and most importantly, is the lack of adequate equipment. So most of the equipment are designed for a coronary disease. And you need a lot of length of the catheters and the balloons and the stents. So currently, the length of the largest, the longest stent is about 130 centimeters. And this is not quite enough to work below the groin. So for the iliacs, I think it has the potential to be applied as a technique, but below the groin, we have still a long way to go. It should be and should never be replaced, especially when you go for total occlusions of the SFA or even below the knee arteries. And for total occlusions, you need a lot of pushability. Then obviously from the radial artery approach, a lot of pushability is being lost across the arch and the thoracic aorta. So pushability is reduced by the length of the axis. So still the femoral approach will be used, I think, for below the knee arteries. I think it's very difficult to be replaced. There is research ongoing. I think with regards with other applications, in coronary we have a lot of data showing that the mortality and the morbidity have been greatly reduced by the use of radial approach. For PAD, I think many randomized trials can be designed to prove that the mortality and the morbidity is reduced. Because, of course, one major advantage is that you can work from the radial artery without stopping the anticoagulation. I think for the heart, for the coronaries, this is essential. For the PAD, is not as essential, I suppose. So I think we have a long way to do maybe a randomized trial. Maybe we can design the trial to treat the SFA lesions, which could be feasible. And then compare both approaches to see whether the complication rate is lower. Definitely the patients love this approach because they are able to mobilize immediately. And the bleeding complications are also almost eliminated. So in terms of safety and patients' comfort, radial approach is fantastic, but we're still very much restricted by the technology. So I think that the industry has an incentive to develop devices for PAD from the radial axis. I would treat an iliac lesion from a radial approach, transradially. A renal artery stenosis or mesenteric artery stenosis, I definitely would use the radial approach. So this is also PAD in many terms. I would treat SFA disease from a radial approach if it's a simple case to start with. And then I have to build my expertise. It's known that you cannot just go ahead and try it. You have to get proper training. It can be complicated if you don't know what you're doing. And of course, we need to look what the cardiologists are now doing and develop devices suitable for PAD. So industry definitely has to look at it, and there is bright future in my perspective.